Hello everyone, Alex here. I'll be a moderator on today's event. Welcome to our webinar, Chronic Pain Syndromes. Before we get started, I'd like to go over a few items so you know how to participate in our webinar today. Now, you've joined the presentation listening either using your computer's speaker system or you can call in on the telephone. I see we have a mix of choices there in our audience. Simply check out the audio pane in your control panel there to switch between those two options if necessary. Now, you will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You can send your questions in at any time, and we'll collect these and address them during a designated Q&A session at the end of our presentation. Lastly, you'll also receive a follow-up email within a day or two with a link to submit your license information from the CEU Institute for your CEU credits for joining us today. Now, please remember that you must attend this webinar in its entirety and participate in all the poll questions to qualify for CEU credit. So keep an eye out for those polls. Now, I'd like to introduce our speaker, David Raptosh, Regional Director of Work Strategies in Select Medical's Outpatient Rehabilitation Division, NovaCare Rehabilitation, Select Physical Therapy, and Kessler Rehabilitation. David is a graduate of Misericordia University and is a board-certified licensed occupational therapist. He is also a graduate of St. Francis University with a Master of Human Resources Management and Industrial Relations. David is an expert witness, peer review utilization review specialist, consultant to the employer and insurance industries, and a human resource management consultant. He's a certified instructor in employment testing, pre-work screening, functional capacity evaluation, injury prevention, on-site employer services, ergonomic injury prevention, and job site analysis. David is a faculty member with the Pennsylvania Bar Institute, Pennsylvania Bureau of Labor and Industry, Workers' Compensation Division, the foundation of the Pennsylvania Medical Society Lifeguard Program, and the CEU Institute. Welcome, David. It's all yours.
Well, thank you very much, and I'm excited to present on chronic pain syndromes. Today we will be discussing fibromyalgia, complex regional pain syndrome, and chronic fatigue syndromes. So with fibromyalgia, if you look back from the 1900s, some of the terms that were used to identify the history of fibromyalgia and the disease was Charcot's hysteria, Gower's fibrositis, Gram fibrositis. Also, you may hear or come across terms from Bolin, Smythe. They renamed the fibrositis syndromes and linked them to fatigue and sleep abnormalities. And also in the 80s, the Epstein-Barr virus, or EBV, was also a term that was classified as really the fibromyalgia syndromes. And now it's linked to non-restorative sleep disorders. But the term used today is the fibromyalgia, and that's what we come across mostly. The AMA endorses the syndrome. The American College of Rheumatology identifies the classification criteria, and as well the American College of Rheumatology publishes a more definitive guidelines that are more useful and reproducible. So fibromyalgia is the term that we call it today, and that's what we'll be discussing. There's a criteria for diagnoses, and it's the WPI, or widespread pain index, is one of those diagnoses criteria, as well as the symptoms scale, and they're abbreviated WPI or SS, and the symptom scale rates the degree of cognitive symptoms, unrefreshed sleep, fatigue, and number of somatic symptoms. The widespread pain index is qualified as greater than or equal to 7, and the symptom scale greater than or equal to 5. Or if you have a 3 to 6 widespread pain index and a greater than 9 scale of the symptom scale, then it would be qualified for the diagnoses. So as a history, the AMA and American College of Rheumatology still have some question about the existence of fibromyalgia. Obviously, fibro is fibrous and tissue related, and myalgia, or myo, is muscle, algia is pain. So fibromyalgia is classified by the widespread pain musculoskeletal type, and it's accompanied by fatigue, sleep, memory, and mood issues. There is no evidence on X-ray or lab testing. The diagnosis depends on identification of the symptoms, any exclusions of other conditions, but there may be overlying other symptoms or diseases that actually can go along with this process. It takes an average of 5 years and oftentimes 4 doctors to be correctly diagnosed with this type of condition. From the old guidelines, there was a chronic diffuse pain which lasted more than 3 months as a diagnosis guide. Pain in all 4 quadrants of the body, meaning the arms, the legs, and the trunk, all 4 extremities. Positive in 11 to 18 specific tender points, and pain identified as discomfort when number 10 pounds of pressure is applied to a tender point, and that is a measurable pressure that's objectively measured by a force gauge. Under the new guidelines for fibromyalgia, the patient would demonstrate the WPI, as we said earlier, of greater than or equal to 7, and the symptom scale is greater than or equal to 5. So as we're looking at the symptoms overview, these are the symptoms that are very typical in fibromyalgia: widespread pain, generalized aches, non-restorative sleep are the big ones, as well as the complaints of fatigue. The individuals do and can have stiffness, tension headaches, painful periods. Does relate to signs and symptoms of irritable bowel syndrome, numbness and tingling, skin changes, swollen glands, dry eyes, cognitive dysfunction in 20%, psychopathology in 5 to 20%, and as well concomitant RSD, or Reflex Sympathetic Dystrophy. So why is this so hard to get the diagnosis? When rheumatologists often are the ones that make this a formal diagnosis. As you see, 5,000 in the U.S. for 6 million patients. The consultants give a thorough review of the symptoms and signs, but the screenings, they really should include lab testing to rule out any other diseases, particularly the CBC, urinalysis, blood chemistry panels, and serious and treatable disorders should be also ruled out before a patient is diagnosed with fibromyalgia. So that's why it does take often a long time, several years, to actually get this diagnosis. And if they have fibromyalgia due to another type of disorder, it will not improve until that primary disorder is addressed. As a nice little tool here, this was one that Irma Bombeck said, never go to a doctor whose office plants have died. So we want to make sure that the physician is aware of the diagnosis and up to date. So who has fibromyalgia? Well, women are impacted 9 to 10 times more than men for this type of condition. It affects over 6 million Americans and 2% of the population. Ages 20 to 55 are the primary ages. 28% of children of mothers with fibromyalgia symptoms do obtain fibromyalgia. And 66% of the people with fibromyalgia had a parent that may have had a chronic pain diagnosis type. It's a syndrome rather than a disease. And as Jack Benny once said, I don't deserve this award, but I have arthritis, and I don't deserve that either. So pain, it may be inevitable, but misery is optional. As we see, pain is the most common symptom of fibromyalgia. It could start in one region of the body and spread. Usually it begins in the upper neck area or the upper trapezius regions and the scapular regions and tightness. It's intense in one area, then disappears and reappears in another area. It varies and is dependent on the time of day, the activities. Oftentimes, when we treat people with this type of diagnosis, the individuals will say, well, I tried to do as much as I could on such and such a day, then the next day I couldn't get out of bed. So we do see their functional abilities affected, and as well, tender points are identified versus trigger points. And the tender points that are identified are in particular areas of the body that can be objectively identified. Fatigue is a major factor. 90% of the individuals have a moderate to severe fatigue level, which can vary from day to day. Sleep is disturbed, and oftentimes non-restorative sleep occurs. When sleep is disturbed, patients with fibromyalgia will demonstrate phasic alpha sleep, which is correlated to their increase in their symptoms. And it leads to a decreased stage 4 sleep or delta sleep, which is the restorative portion of sleep for the musculoskeletal system. We need that restorative phase in order to feel better and feel refreshed. Many people with fibromyalgia or fatigue try to take sleeping pills to overcome the sleep issues, and the sleeping medications that can affect them, they become oftentimes dependent on sleeping medications or other drugs or foods that they may experience for this type of syndrome. Many people are smokers or drink alcoholic beverages to help assist with sleep, and the environment could be a stressful environment, or just from having pain from other conditions may be affecting their actual sleep and actually their total fatigue. There have been studies which correlated fibromyalgia and depression especially with increased pain. Rarely pre-study psych tests are available, and the psych tests are usually derived before fibromyalgia is characterized. Oftentimes reactive depression could be present, and most of the chemical and hormonal changes associated with fibromyalgia are not associated with behavioral conditions alone. So what tends to happen is the fibromyalgic patients don't have more psychotic or obsessional or hysterical or hypochondriacal episodes than the general population. So you see the depressions that can occur there, and many patients have that feeling of blue, but only are 25% diagnosed with clinical depression. So that's an interesting identification in the studies that have been done, that many of the people are classified as being depression associated, but the clinical depression diagnoses are not relevant in this condition. As well, physiology of pain, and the research defines the chronic musculoskeletal pain with fibromyalgia as a central sensitization of the nervous system. It's characterized by widespread pain, meaning that it occurs throughout the body and in different places, and it could come and go. There have been studies done by Mises, and that was an impaired functioning of the brain, orchestrated descending anti-nociceptive mechanisms. That was in 2008. Another study by Mises and Nigis in 2007 over activation of descending and ascending pain facilitating pathways. But the net result is the augmentation rather than inhibition of nociceptor or pain transmission. It's a multi-system output that is activated by an individual specific pain map in the brain. The map is activated whenever the brain concludes there is a threat and action is required, and that was adapted from Moseley in 2003. So to understand the physiology of pain, we need to understand the factors that could be involved that create this type of a syndrome, the threats that could occur, or the multiple output mechanisms, and the pain processing mechanisms that occur with the individual. So looking at the threat and what constitutes pain, as in nociception, could be from work, stress, family problems, failed or undiagnosed medical problems, are all perceived as that threat. In the brain, it doesn't necessarily process pain in clear detail, but instead it represents, what it represents is in terms of the threats above, it takes those levels and elevates the pain level for the individual with fibromyalgia. Unknown etiologies could be part of this condition. Fibromyalgia may be from a threat of unknown conditions. It just happens, stress-related, and what causes stress in major daily life activities. It could be anything that's occurring. Illnesses could be part of this process, as well as direct pain from other conditions. Childhood traumas, family histories, history of sexual abuses are all found as part of, that could be part of the pain threats in the development of fibromyalgia. Work issues or disability, as well as genetic predispositions. So the immune system can be also looked at as an output mechanism, parasympathetic system and the GI system. These have all been thoroughly studied and looked at with fibromyalgia cases, and there isn't a specific system or systemic illness that makes this diagnosis occur. So it could be any of these as part of the process. Treatment is a focus of education, and education is very important to assist with sleep and dealing with the fatigue issues, gradual reconditioning of muscles, as well as the fibromyalgia is not curable, but can be managed in a manner that improves quality of life. So those individuals that often are known to overdo it need to understand pacing principles and be able to carry out activities throughout a day without overdoing it and then being laid up for the next several days because of the activities that they previously performed. So as we see in the medical management model, the education, and what's important is explaining what the condition is and what it's not. Cognitive behavioral therapy is a tool that is used, and it's been very successful in working with the fibromyalgia population. Pharmacotherapy, we see anticonvulsants, a tramadol can be utilized. Different medications, I believe Lyrica has been utilized as a medication, and we also bring them all together with, on the other side of the model, physical therapy for exercise, and it's graded exercise that's most important, and allowing that individual to actually perform exercise that allows them to become stronger, to minimize the fatigue, and also to improve the muscle strength and conditioning level, both aerobically and from a muscular standpoint. Psychological and psychotherapy support groups have been utilized, as well as ways to address sleep dysfunction, sleep labs, and depression and anxiety. So looking at all of these factors for a multimodal therapeutic approach is going to be recommended for strategies to help the individual with fibromyalgia. It's not just a one unilateral type of system model. It's a management model which combines many different areas to help these individuals. So with treatments, most effective treatment requires a comprehensive program with all of the above: the medication, the exercise, the relaxation, and education regarding the disease, and understanding healthy habits to maintain the body and the system. So the medications with tricyclics, which relieve sleep disorders, reduce the muscle pain, and help to treat the underlying depression. The tricyclic drugs most commonly prescribed, Elavil, is amitriptyline, and that's mostly used. And another class of antidepressants are the serotonin reuptake inhibitors, or SSRIs, and they'll boost the level of neurotransmitter serotonin in the brain, modulating mood, but also doesn't improve the physical symptoms, and that's the Prozac, is one of the most commonly prescribed SSRI medications, fluoxetine. FDA-approved medications, Lyrica, as I said earlier, back in 2007, Cymbalta in 2008, milnacipran, and other medications, tramadol, NSAIDs, and opioids have been used. Actually, the opioids, though, we're finding, may make the actual pain worse. In 2007, the FDA approved pregabalin, or Lyrica, to treat the fibromyalgia, and the drug reduces pain and improves function in some of the patients. It's been very, very promising. Small doses of aspirin or acetaminophen may provide some pain relief and relieve muscle stiffness. And the NSAIDs, the ibuprofen, Aleve, narcotics and corticosteroids, prednisones, have not proven to be effective with this type of a diagnosis. So again, the Lyrica seems to be the most promising and the best medication of choice right now. Exercise is a part of a treatment. It has an enormous benefit for this treatment group, and the exercise must include the warm-up exercise modes, cool down. In the warm-up stages, obviously the stretching, gentle stretching and flexibility. The cool-down phases are very important after the exercise is performed. Working on endurance and conditioning, or aerobic conditioning, for the individual, as well as having the patient understand what their levels of discomfort and pain are as they're going through the exercises, and allowing full range of motion during the exercise activities. For physical therapy in fibromyalgia, exercise and education would be really the goal. Educating the individual would be the goal, and allowing the individual to understand how to exercise correctly would be the most important goals in this type of a diagnosis. We address the musculoskeletal triggers as well as any core weaknesses and stiffnesses in the thoracic spine or the entire spine, the cervical, thoracic, and the lumbar spine. But thoracic, for the fibromyalgia in the thoracic or mid-back region, is often one of the areas that creates stiffness because the individual does not move that area of the body very often. They kind of stay in a guarded position with the shoulders rounded over, and that area becomes very stiff. Patients that are educated in posture, body mechanics, and the workstation setup for ergonomics, very important if they're working throughout the day, and working on proper posture principles and pacing themselves, not overdoing it to the point where they can't function over the next day. Patients will progress slower and often need more rehab if they don't understand what the fibromyalgia is all about. So the education is very important. And it's important to have the individuals follow a home exercise program, especially on the weekends and the days in between the therapy when they're attending. Patient compliance, very important with the program. The individual would be taught self-management techniques so they understand what their pain physiology is, how to document and understand the effects of positive environments and negative thinking. The stages of the grieving process are also discussed with these individuals because of the coping mechanisms and unhealthy thinking that they may encounter. So 5 habits of successful self-managers: join a healthcare team, assume responsibility, learn as much as you can about the illness, master your emotional challenges, and develop a wellness lifestyle is what's recommended. In treatment, healthy habits for underlying sleep disorders. Sleep needs to be addressed and identified as part of the condition, and basic good sleeping habits should be understood by the patient. Again, following schedules, eating meals prior to well before bedtime, and as well the same with exercise, providing exercise well before bedtime so that the individuals can have a restful sleep. Healthy habits, avoiding smoking, drinking, and good sleep hygiene and nutrition. And also the alternative therapies may be promising for acupuncture, massage, yoga, Pilates, trigger point injections. These all may be part of a pain management type of program with this population. Some of the associated syndromes with fibromyalgia: regional myofascial pain. You may hear of this diagnosis, or may hear of chronic fatigue syndrome, or other overlapping syndromes that can occur with tendinitis and muscular-related conditions. Some overlapping syndromes: multiple chemical sensitivities, Gulf War syndrome, silicanosis, leaky gut syndrome, mercury amalgams, and urethral problems could be also part of this syndrome, and that's caused from overlapping syndromes. Work is an important area for all of us, and 90% of fibromyalgia patients who wish to work are able to work. That's what's interesting in this diagnosis. 60% of the fibromyalgia patients are working full-time, so that leaves 30% of the patients not working, either on disability or because they choose not to work. So the 30% of the patients had to change jobs. That would be out of the 60% that are working full-time. 16 to 15% of employed fibromyalgia patients on some type of disability. So that's a high number of individuals that are actually receiving disability for this type of a condition. A study of light to medium jobs showed that fibromyalgia patients did only 58.6% of the work of their healthy coworkers. So when they are working in a light to a medium physical demand level, their output or productivity does not match the healthy workers. With the fibromyalgia patients, there is a discrepancy between their perceived work abilities and what is viewed on video of their work performance. So studies have been looked at and showed that their perceptions often don't match what their actual real performance is. And it's not considered a disabling condition by the U.S. government, which is interesting to hear. So it's difficult to have this diagnosis and be classified for the Social Security Administration's definition of disability. So in summary, fibromyalgia is a medical condition. It can be managed, and when recognized by caring medical providers, be treated. The management requires multidisciplinary approaches for successful treatment, and also requires the individuals to be part of the program to actually work with home programs and exercise and education. Research is being performed and published nearly daily so constant review of current evidence is critical for the effective current treatments of this type of diagnoses. And we've come a long way, I believe, since the early 2000s, when it was primarily Epstein-Barr virus, and we thought it was particularly a virus that was causing this type of a condition. Now we're understanding it better, and we're able to treat it more effectively with some of the other therapies, and we're having more success. Do we want to bring the questions up at this point?
So we have our first poll question. If everybody could take a second to log their answer. Keep it open for about a minute. This is our first poll question of the webinar. And just a reminder to send text questions, and I'll keep them till the end for David. We'll give another second. We're about 90% complete. All right, I'm going to close the webinar up and back to David.
Okay, thank you, everyone. I'll leave that up for a second. The next area that we're going to discuss is complex regional pain syndrome. And complex regional pain syndrome is a chronic pain condition that's believed to be a result of dysfunction in the central or peripheral nervous system. Typically features dramatic changes in color and temperature of the skin over the affected limb. And it could be the hands or the feet, which primarily this condition appears in. It could be one hand, two hands, one foot, or both feet. It's intense in burning pain, intense in skin sensitivity, and also sweating and swelling. So the confusion related to complex regional pain syndrome. What are the symptoms? Why is it so misdiagnosed? How can it be treated? Will the injured employee be able to return to work? These are all questions that we as clinicians and case managers, adjusters, as well as the therapists and physicians all deal with. Not every case experiences complex regional pain syndrome, and the individuals that do, it generally occurs over a period of time. It's one of those syndromes that don't actually occur on an acute phase. It occurs as the condition continues to go through its etiology. So as we're going through and seeing what complex regional pain syndrome is, in the past it used to be identified as RSD or causalgia. So in 1995, the APA changed the RSD name to chronic regional pain syndrome. And as you see in the extremities, these are a lower extremity, the swelling and edema that's actually occurring in the extremities. Not only the right leg, but the left leg also has edema that's associated with it. And sometimes it can occur in both extremities when only one extremity has been injured. 100,000 to 1 million new cases a year. That's a huge variance. 2 to 1 in women versus men that may experience this diagnosis. And between the ages of 40 to 60 are when it most occurs. Minor traumas could be a part of the condition, so with meaning minor traumas or bumps and bruises with no nerve involvement, or fractures. We see this condition occurring in both, as well as in major traumas where there is nerve involvement, gunshot wounds, any types of surgical procedures or repairs. We typically see this most often from injuries that are occurring with major trauma. There are 2 branches of the nervous system in the body, the voluntary nervous system and the autonomic nervous system, or parasympathetic and sympathetic. The parasympathetic restores your equilibrium, but the sympathetic is your fight or flight and that's where your heart rate, blood pressure, and sweating occur from. So they believe that these are all part of the complex regional pain syndrome diagnoses and branches. So as we see right here, when we're looking at the mechanisms of RSD, you have the injury that occurs on the left side of the screen to the right hand, and there's like a hand-wrist injury that's occurring there. As you see, that pain goes up to the brain. And in the brain then, the original injury initiates a pain impulse, and it's carried by the sensory nerves to the central nervous system, which go down from the brain through the spinal cord. And then from the spinal cord, it goes through the sympathetic chain of nerves, and the pain impulses turn into triggers and impulse in the sympathetic nervous system, which returns to the original site of the injury, back to the hand or arm. So that's typically how pain reacts. But the sympathetic impulse triggers the inflammatory response, causing the vessels to spasm and lead to swelling and increased pain. So that's where it just continues to happen. You have that swelling, pain, which keeps triggering back and forth. And then when that pain triggers, other responses occur in that cycling effect. So the swelling doesn't go away, the skin changes, the skin color changes, the temperature of the skin changes, as well as the hand or the extremity becomes mottled in, you can see patchiness or redness, mottling of the skin, sensory or I'm going to say paresthesias can occur, or numbness, as well as very sensitive skin. This is probably one of the best mechanisms to show how the pain responses work in receptors and how it goes through the body. So the theories of complex regional pain syndrome, there's an abnormal reflex arc. In a normal response fails to shut down due to an increase in the afferent impulses. Those are nerve impulses. And there's abnormal sympathetic reflex loops, and that abnormal feedback at the spinal cord level could be a theory that's going on here. Or there's an increase in pain, which is a producing substance that continues over and over and over again, like a chemical response. They question whether complex regional pain syndrome has anything to do with nerve entrapments, and there's studies done on that, and they may say that there is or isn't a specific correlation there. In an article by Nelson Hendler and colleagues report that 70% of the patients sent to a clinic with a diagnosis of CRPS or CRPS type 1 actually have nerve entrapment syndrome. So 70% could have that, and that article is identified right here in this journal. So what are the symptoms? As you see in the picture, obviously swelling and edema, burning pain, stiffness in the joints, and that stiffness is because of the swelling. You can't move the joints, and when you don't move the joints, the least movement, that swelling stays. There's venous pumps and lymphatic pumps in the hand and in upper and lower extremities, and if those pumps aren't activated to pull that lymph and swelling out of the hand and upper extremities or lower extremities, then they remain edematous and stiff. The entire extremity becomes stiff because of the fact that the individual doesn't move, and they posture and can keep their extremity in a position that it's non-functional, and any movement at all that occurs to that distal extremity because of the swelling and edema, as you see, the skin is shiny and red, but not just in the hand and the wrist area, it occurs up through the entire arm. At the elbow, because that hand and wrist isn't moving, the elbow and shoulder aren't moving either because the individual is guarding their postures. As we see in blotchy, discolored colorations of the feet and the lower extremities, the increased edema in both lower extremities and both feet. Temperature changes can occur and use the graphs, and you can see where the temperatures are actually the redness in a more normal type of an extremity, but you see the blues and the greens in the other left foot of that picture shown there will show typically with this type of a diagnosis. Increased skin sensitivity, shiny skin, changes in nail growth and hair growth on that extremity are often noticed where there's no hair at all, or hair that occurs in patchy areas. The individual has difficulty sleeping because when they move, that sensory sensitivity wakes them up from sleep because of the pain. It's recommended for treating this condition early. Case managers and adjusters be aware of the signs and symptoms that the individuals are showing out there. Be aware of the tests that can expedite the type of diagnosis, and have physician contacts that you really trust with the diagnosis. Oftentimes, physical and occupational therapy is initiated very soon when this diagnosis is identified, so that we can get the individuals functioning and back to a functional level or a normal level as soon as possible, and keep the communication lines as open as possible. So in diagnostic studies, thermography, non-invasive, and that's one of the great tools to use. You can see the thermography, it shows the extremity that would be the left upper extremity, or the picture on the left or right side of the screen would be the left hand, shows the decreased temperatures throughout from really the forearm down through the hand. Diagnostic studies, X-rays, as you're noticing here, could be some uncomplicated tests, but radioactive tracers may be utilized to show any bone densities and bone areas that could be affected. Physiological tests rather than an anatomical test, which reveals what is happening to the blood supply of the bone rather than just taking the picture there. Nuclear scans may also be helpful in identifying these types of conditions. And as you see, the bone, the different bone changes that can occur with this type of a diagnosis. Another type of diagnostic study is an intravenous phenethylamine injection, and increases blood flow by expanding the blood vessels and smooth muscle. And the overall goal is to determine if pain is maintained by the sympathetic nervous system and show whether or not a patient's symptoms will disappear when these receptors are blocked. Sympathetic blocks can be used when there's injected medication used as a block in the sympathetic ganglions and the cluster of sympathetic nerves outside the spinal cord. So if pain is relieved, it supports the chronic regional pain syndrome diagnosis. Invasive injections, and individuals can develop facial and swallowing symptoms, but should always follow immediately with therapy if used in treatment with any of these types of blocks. So we have to be careful that the individuals don't have other symptoms related to the blocks that could occur. Epidural blocks will block the motor, sensory, and sympathetic nerves all at once. So it does not diagnose or differentiate between the chronic regional pain syndrome or radiculopathy or peripheral nerve entrapment syndromes. It's just used to block all the motor, sensory, and sympathetic nerves. The 3D CT scans may diagnose hidden fractures not seen on regular exams, and that may be useful for the appropriate treatment. EMGs, or nerve conduction studies, it differentiates the chronic regional pain syndrome from nerve entrapment syndromes, but it is noxious. When you utilize needles in the skin, it's very painful to the individual. So oftentimes individuals with this diagnosis cannot tolerate the EMG or nerve conduction studies because of the pain levels that they're having. These studies have to be terminated oftentimes because of the noxious stimuli that's presented. So with some treatment options, therapy, obviously, physical occupational therapy, sympathectomies have been used as a treatment option, steroids and exercise, epidural electrical stimulation, morphine pumps, medications, and we don't want to see this, but amputation has been used in some rare cases. Physical and occupational therapy are utilized to gradually increase programs and functional activities to keep the joints moving, the range of motion, as well as movement patterns to decrease the edema, to educate the individual on self-management when they're not in therapy, and home exercise programs. And therapy should never cause any significant increases in pain. Therapy should be utilized to help the individual manage their pain and be able to improve their functional performance. Psychotherapy has been found to be effective on some of the people with this type of a diagnosis and also their families. So individuals with chronic regional pain syndrome may also, like the fibromyalgia, have depression episodes, anxiety, post-traumatic stress-related types of disorders, all of which heighten their pain perceptions. When an individual has psychosocial or psychiatric illness in conjunction with this type of a diagnosis, it does make rehabilitation more of a challenge, but the appropriate treatment and identification for psychotherapy can be beneficial. Sympathetic nerve blocks. Some patients will get significant pain relief from the sympathetic nerve blocks, but it's most useful when combining therapy with the nerve block. So it's not just one tool that actually will help this population. Medications of many different classes are used, from topical analgesic drugs that can act locally on the painful nerves, skin, and muscles, anticonvulsive medications, antidepressants, corticosteroids, and opiates are often used with the type of a diagnosis, but there's no single drug or combination that has really provided any consistency across the treatment regime. Surgical sympathectomy, it destroys the nerves involved and is controversial. Some experts think it is warranted and makes the chronic regional pain syndrome worse. Others report a favorable outcome. It should be only used in the patients whose pain is dramatically relieved, although temporarily, by the selective nerve blocks. So if it's not relieved by the nerve blocks, then this should not even be looked at. Spinal cord stimulation is another option of treatment, placing the stimulating electrodes next to the spinal cord, and it provides a pleasant tingling sensation in the painful area, and it helps some of the populations with this diagnosis be able to actually cope with the levels of pain and tolerate their level of pain. Actually, it may provide also better ability to move the joint and decrease some of the edema. Intrathecal drug pumps administers medication directly to the spinal fluid so that the opioids and local anesthetics can deliver pain signaling targets to the spinal cord, and the doses are far lower than those required for oral administration, decreases side effects and increases the effectiveness. These are some of the last efforts of managing this type of a diagnosis. The most flagrant abuse is the overuse of the sympathetic blocks. 6 to 12 blocks is considered enough to determine if it's going to work for this condition. And the blocks will provide a treatment by themselves. The blocks will only work temporarily, and a patient may need the sympathectomy, or the blocks don't work and the patient does not have complex regional pain syndrome. So that's what's used to either identify the diagnosis as well as rule it out, or identify that the individual does not have the condition. So in summary, it's important to establish an accurate diagnosis of RSD, or complex regional pain syndrome. Early identification and treatment is essential. Pain-relieving medicines can be utilized. Exercise that is managed and gradable 3 to 5 times a week is utilized to help these individuals. If that doesn't work, the sympathetic blocks, which may lead to a sympathectomy, may be utilized in some cases, and delaying treatment for this type of a diagnosis often is disastrous, and it does not lead to appropriate outcomes or positive outcomes in the case. We are at the second question now. And chronic regional pain syndrome symptoms include all of the following except, let me get a page up here.
Going to close this one pretty soon, and then David's going to try to get through the next couple slides to the last poll question. Mm-hmm. Right, going to close the poll up.
Can I move on?
You're good.
The last section is chronic fatigue syndrome, and it's identified as a chronic illness of uncertain etiology characterized by at least 6 months of debilitating fatigue and associated symptoms. This is one of the definitions that were identified for this syndrome, and in the past it was identified as neurasthenia, myalgic encephalomyelitis, chronic Epstein-Barr virus disease, and chronic fatigue syndrome in 1988. This chronic fatigue syndrome, the symptoms of the syndrome are all nonspecific, and some but not all are seen in psychiatric illness. The symptomatology is suggesting an organic component to the illness, and it includes its abrupt onset with an infectious-like illness, intermittent, unexplained fevers, arthralgias or pain, and gelling stiffness, sore throats, coughing, photophobia, night sweats, post-exertional malaise with systemic symptoms. The illness can last for years and associated with marked impairment in their functional status. Fatigue is the primary symptom, and it's a severe incapacitating fatigue that isn't improved by bed rest, and it's often worsened by physical activity or mental exertion. It's an all-encompassing fatigue that can dramatically reduce a person's activity and stamina levels. So the symptoms are increased malaise or extreme exhaustion, sleep difficulties, memory and concentration difficulties, persistent muscle pain, joint pain, headaches, tender lymph nodes, sore throats. Any additional symptoms could include brain fog or feeling like you're in a mental fog, difficulty maintaining upright positions, dizziness, balance, allergies, sensitivities to foods, odors, chemicals, irritable bowel, chills, night sweats, visual disturbances, depressed moods, mood problems, which could be irritability, anxiety, panic attacks, and mood swings. The clinical course of the chronic fatigue syndrome, and most people do obtain a fairly active lifestyle, however, have significant limitations in work, social, and family activities over time. Periods of illness are followed by periods of relative well-being, so it's a ebb and a flow for this type of diagnosis, with relapses which can occur when in remission, when tempted to overdo activities when feeling better. The major problem with evaluating the effect of therapy in chronic fatigue syndrome is that the symptoms do fluctuate. They can remit spontaneously, and they also may significantly respond to a placebo, which is very interesting. So the polling question with chronic fatigue syndrome, symptoms will fluctuate and will remit spontaneously and may respond to a placebo. So that is your question, and I think we are right on time.
Yep, let's everybody get this the last poll question. Everybody get their votes in, true or false. We're about 90%. Everybody get them in, true or false. All right, we're coming up on a minute, and I'm going to close the poll. Go ahead, David, if you want to continue the slides. Everybody, you can stay on the line if you'd like. David's going to finish up the slides, but you can drop off if you have other arrangements you need to get to.
Just about 3 more slides to go through. Unproven treatments for this diagnosis are antivirals, gamma-globulin, corticosteroids, vitamins, interferons, bovine porcine liver extracts, and so forth. They're all unproven, as well as fatty acids, peroxide, colonic enemas, removal of fillings, garlic, ginseng, shiitake mushroom extract, all unproven treatments. Unproven vitamins and minerals, CoQ10, vitamin B12, zinc, iron, L-tryptophan, magnesium sulfite. These are, again, unproven vitamins and minerals for this diagnosis, which aren't considered workable solutions. Treatment for this type of diagnosis, interesting, cognitive behavioral therapy is often utilized with graded exercise, and it does appear to produce a meaningful benefit, and that was in a study done by Strauss. Lancelet had a study, and it compared with adaptive pacing therapy, cognitive behavior therapy, and graded exercise therapy, and they found that they were less associated with less fatigue and better physical functioning. So the promising effects for treatment of this type of diagnosis, cognitive behavior therapy and graded exercise, can be safely added to specialist medical care to moderately improve outcomes for chronic fatigue syndrome. So in the future, current studies may lead the way to better and more specific treatments. We know that they're looking at other studies for neuroimmuno and endocrine interactions, genetics, as well as other infections, XMRV, which refers to recently discovered retrovirus called the xenotrophic murine leukemia virus, and they're looking into that. And these are some of the resources that I found to provide to you, and they will be available to you. And as well, the international research for RSD, complex regional pain syndrome, the American Chronic Pain Association. And any questions, you can always get a hold of me at the address or telephone number below, 717-580-8749, or my email address, draptosh@selectmedical.com. I'd like to thank you all very much.
Awesome. So we're going to forgo the question and answers, but I did collect all of them, so I will send them to David to see if he can answer them, and then I will send out with the presentation to all of you that joined us today.
Excellent. And thank you so much, Amanda. And thank you, David. And thanks to all of our attendees today for attending our event, Chronic Pain Syndromes. Now, once you leave today's webinar, you will receive a survey on today's presentation. And we would greatly appreciate your feedback and participation in that survey. You'll also receive a follow-up email from the CEU Institute within a day or two with a link to submit your license information for your CEU credits. And then lastly, you'll receive a copy of our presentation and a link to view a recording of today's webinar. Now, on behalf of Gen X Services and our speaker, David, we want to thank you all for joining our webinar and wish you a great rest of your day. Thank you so much.
Thank you.